Okay.
Sounds good.
Hi, everybody. I'm Wendy Murdoch, and this is Webinars with Wendy. As you know, we continually bring in more interesting new guests. My guest today is actually Lola, and she's not new to me, but she's new to the webinars. I met Lola
2011.
Yeah, a long time ago. And then we kept bumping into each other, like at RRP, the Retired Racehorse Project. And then I came out to your place and did a Surefoot workshop, which I absolutely loved because I love the Northwest. Yeah, it was great. It's on Vashon Island, one of my favorite places to visit, which I haven't.
Yeah, we miss you here too.
Yeah.
We got to get you back out.
Yeah. And so I'm just going to turn it right over, let Lola introduce herself, and we'll get right into her topic because I'm really excited about this. So welcome, Lola. Thanks for joining me.
Thank you, Wendy. Super excited to be here. And yes, my name is Lola Michelin. I'm the founder and the director of education at the Northwest School of Animal Massage. And I've been in the animal bodywork industry for a little over 3 decades, starting back on the East Coast. In my youth, in my 20s, I worked at the racetracks, and that's kind of where I first got introduced to massage. And from there, throughout my travels, I just kind of kept adding layers to my practice. And eventually I was encouraged by a good friend of mine to start teaching and holding some clinics. So we did that, and I had a lot of fun with that. And so out of that came the school, and that's where I've been devoting my energies in the last 24 years.
Yeah. And so the school was kind of organically just kind of came out of. Tell us a bit about your school, because I think I don't know that people on the East Coast, I'm on the East Coast, really know.
Right. Yeah. So as I said, the Northwest School of Animal Massage is based in Seattle, Washington. We do have campuses throughout the country, and we've taught internationally as well. So our base is here, and it's been here since its inception. And about 10 years ago, I did relocate to Vashon Island. So I was in the east side of Seattle for many years when the school first started. And then we relocated onto Vashon Island, and we bought a farm here, and we run an equine retirement and rehabilitation program alongside of our courses. So that was a real game changer because it really expanded our ability to kind of host the conversation locally. And but I still continue to travel and teach in other parts of the country and other parts of the world. So especially
you work with some really exotic animals, right?
I do. I do. So that's kind of my other passion. I mean, horses, of course, are a huge part of my life, but my other passion is exotic species. I did work in the zoological field. Out of college, I went directly into working at a zoo in conservation education, which was a blast. And as a vet tech, I also got the opportunity while I was there to work closely with the veterinarian clinic. And so I ended up on several cases, and there were just some really unique opportunities when you're working with that type of population. Sometimes, you have to do things in an unorthodox way because you're handling an animal that you have to create a certain safe way to handle that animal or work with that animal. And of course, you're constantly having to adapt to, well, this animal's behavior is such and that animal's anatomy is different. And so it was a really creative time. And the vet clinic there was very open to massage. Okay, why not? Let's try. Or, acupressure sounds great. So I did get to do a lot of work with exotics that has carried over into my equine work, and still continue to consult with a number of zoos, including here in Seattle with the Woodland Park Zoo. They have an absolutely amazing animal healthcare team, and they pull in people from all over. I wish, several years ago, we had a giraffe that was born, and he was collapsed in the pasterns, but also his hocks were like jello. So he couldn't stand. Consequently, he couldn't nurse. And so, it was looking grim. And so they put together an animal healthcare team, and the veterinarian there, who I'm friends with, invited me in, and we used a combination of kinesiology taping and laser therapies and a specially designed platform shoe for him. And I'm pleased to say he fully recovered. He's now a mature male and living a great life. But I wish then that I'd known about the Surefoot pad system, because I would have been like, oh my gosh, this is, we got to use Surefoot pads with this little guy. So exotics have been a really fun part of my career as well.
Yeah,
and we do trainings too for zookeepers.
Well, I think it's so interesting to work with exotics because unlike horses, you can't put something on their head, and you can't. They're not domesticated, so right. The interaction is totally different, and you have to find really positive ways to deal with them, to help them cooperate with you in a way that they're not threatened. And it's not easy to treat things when they're in pain, and trying to find ways to help them. So it takes a team. I know that, I've talked to people that have like worked at SeaWorld and Disney World and stuff like that. And it's so fascinating because they come from a very different perspective than horse people in terms of team, organization and structure and discussion. And so it's really great that you have that.
I have a funny story related to that. I'll make it quick, but one of the curators at one of the zoos that I worked at, I was going to be coming out to teach his zookeeper staff basic massage, and we were going to be looking at several species. And so he wanted to come out first and spend a little time with me and learn some of the stuff so that so he knew what he was getting into, I guess. And so I said, yeah, come on out. So he came out to the horse farm that I was at the time, and he walked around with me for a day. And this is a guy he's one of the original people that actually like swam with the whales at SeaWorld. And he works with mainly hoofstock, but like giraffe and rhinoceros and things like that, and primates. And so anyway, he came out and he was walking with me, and we were going in all the stalls, and he was watching the people coming and going. And at one point he turned and looked at me. We were in a stall with the horse, and he's like, "You people are crazy." I'm like, "What do you mean?" He's like, "These are enormous animals who are potentially really dangerous. And like, I get it. You have these relationships with them and they tend to be docile, but like," he's like, "I have animals in my collection that are like that as well, who I have really close relationships with, but who I would never just walk into their space and start doing stuff to them without going through all sorts of protocols." And I was like, yeah, well, that's our world. It's a little bit different, but I've learned a lot from both worlds that I can take to the other. And one of the nice things about working with exotics, because I'm also a human massage therapist, right? So I work with people, I work with horses and dogs, and then I work with exotics. And the communication with exotics is so crystal clear. Like they're very, I don't want to say vocal, but like, where you stand with them at all times. And then like, horses and dogs, because of their domestication, sometimes there is some like disconnect, or there's the learned helplessness that we see in horses a lot as a protective mechanism. And then you get to people and it's like, who knows if what they're saying is what they really mean.
Well, that's so true though, isn't it? It's we've learned how to like cover up what we're actually thinking and do fascinating. Yeah. All right.
Which has nothing to do with manual ligament therapy.
No, but it's always, I love talking to my guests because I love digging into the background a little bit and finding out, how did people get where they are? Because for one thing, I think it's inspiring to those folks who, may want a career in horses or with animals, but also to just, we all come from different paths and different ways in, and that's our strengths. Our strengths are what we bring with us into this space from our prior experience that, someone else doesn't have. Like, I had my accident, so I have great understanding about recovering from really bad injuries, but I could not talk to you at all about having a baby. I have no clue.
Yeah.
Having not had children, right?
Yeah. And, you and I both, having been in the industry for a little bit now, like you just keep layering, like you just keep discovering like, oh, and then you connect it back to I can relate to that because of a previous experience, but you never get to that point where you're like, I have all the tools I need. No, here's one more.
No, there's always more, which is great, which is why I love it actually, that the constant curiosity and looking for new and different ways. And certainly I'm sure that having worked with the exotics, when you work with your students in this, massage, there's an element of that comes in because you can't force them to do it. You have to read them better and that sort of thing. So I think it's awesome that you have that depth of background. Okay. So we should probably get to our topic.
Yes. So manual ligament therapy is a great example of that because it came to me through needing another tool and needing something else. So two things happened that introduced me to manual ligament therapy. And manual ligament therapy was originally developed for in human physical therapy, massage therapy.
What did you do? You're hopefully you didn't leave the room.
No audio?
I got audio, but your video just disappeared.
Oh, really?
Yeah, that was just, and yeah, I have your audio, but
I wonder if I turn it on and off again. I mean, it's on right now on my screen. I see both.
Yeah, I don't see you. Hang on, let me see if I can.
I wonder if people.
Oh, you're back. I have no idea what you did.
Did you not know I'm a shapeshifter?
I guess so. You shifted. That's a new one. That was awesome.
My superpower, invisibility.
It said you left, but your voice was still there. So that's awesome. Okay. Thanks for coming back.
Kind of like my dad. He's gone, but the voice is here. So, so manual ligament therapy. Mm-hmm. So I had a fall. I ride jumpers and had a nasty fall. And as a result, had a back injury, but it was completely idiopathic. Everything we looked at, no disc issues, no nerve impingement, no obvious damage, but I had horrible nerve pain, debilitating nerve pain. So I was looking for something to help with that. And at the same time, I was just finding I was working a lot in the industry at horse shows, and it was at a time where I felt like there was suddenly this real emphasis on mobility, which is great. But it seemed to me like, at least in my industry, horses were being exposed to a lot of kind of aggressive body work, maybe just in the circles that I was in. And also a lot of stretching, which was great, but I was seeing overstretching. So I was dealing with horses that were coming to me with significant hypermobility. And what I would see is right after certain treatments, they would be hypermobile, meaning the joints were just going beyond the physiological end feel of the joint. And then 36 to 48 hours later, they'd be stiff. And so, they'd be like, oh, we got to get the so-and-so out again, or we got to do the thing again. And then they'd be hypermobile again, but they never were stable. And the more I saw it, the more I was like, we need a tool here to help reintroduce stability in the system, because I was feeling like hypermobility was becoming normal to people. And I know that, that was part of my back problems, was that I had hypermobility in my sacroiliac joints. So anyway, a dear friend of mine, who's also a human massage therapist and owns a human massage school in the Seattle area, she reached out and she said, hey, I'm teaching this manual ligament therapy class. I think you'd really enjoy it and benefit from it. So I said, okay, sign me up. I made my husband do it too, because I was like, if this is for me, you got to know how to do it. And we went, and within 2 sessions, my back pain was gone. And I felt a stability that I hadn't known for a long time. And I was like, well, wow, there's something to this. So I started, taking more classes, and eventually I reached out to the person who developed MLT for humans. His name is Art Goal. And I said, I need to learn directly from you. I need to really understand the science of this, because I think there's an application for horses with this, and it might be the thing I've been looking for. So he and I started working together, and I set up a little mini research project with a friend of mine, Joan Sarita. And for 5 years, we just practiced MLT, trying to transfer the human knowledge of MLT to the horses until we figured out a system that worked for the horses. And that's how the manual ligament therapy for horses was born.
Wow. This is so fascinating, because, hypermobility is something that we're seeing more and more in these dressage horses. And we've seen it for when I was younger. For many years in the hunter world, in the riders, the type of rider in the hunter world was a long, lean woman who had hypermobility, right? But not stability. And so I'm fascinated. I'm fascinated by this because, you know, that's what we're seeing in horses now is this kind of hypermobility. And yeah, so tell us more. So I'm just really curious.
Yeah. So, you know, if you look at like physical therapy, I mean, a lot of what we, when we're developing a rehab protocol, for instance, you're looking at creating a stable platform because you need a stable platform to create mobility around that platform. So like the mobile joints have to have a point of stability so that the muscles can do, you know, the movements, and then you can build strength. But if you don't have the stability, you can't build strength on that. You can, you know, the muscles and the connective tissues will respond to hypermobility by splinting or getting stiff so that the movement becomes, you know, a little less fluid, but it's safe, right? So
I'm going to kind of unpack this a little bit because we've got somebody asking if you can explain hypermobility. And I think one of the things we need to talk about there is when you're talking about joints that are supposed to be mobile and joints that are not so mobile.
Sure. I'll use some bones for illustrative purposes. So these are two cervical bones, right? And it doesn't really matter which they are, but it's probably C3, C4. So we've got the two bones, we've got the articulating surfaces, and where they're coming together is going to define what movement is available. So the shape of the bone, it will help to indicate what actions or movements are available. Now, we don't have the connective tissues here, so, you know, realistically, there is some space to allow for things like flexion, extension, and lateral movement, side-to-side bending. But there's going to be a limit, right? There needs to be a limit. So for instance, if these joints are in flexion, they're going to come to a point where, and that's a huge exaggeration of the movement, but just for illustrative purposes, it's going to come to a point where physiologically the bones don't want to keep moving because there's some kind of opposition, right? So there's barriers to movement, natural barriers to movement. So the first barrier is going to be this physiological barrier where we either have the bones opposing one another or we have soft tissues opposing one another to tell the body, like, maybe start to think about stopping, right? So that we don't go past that physiological barrier into what we would then call the elastic barrier. Your elastic barrier is where the soft tissues start to say, like, okay, maybe we can give you a little bit more by stretching ligaments or stretching the joint capsule. So now we're in this more elastic space, which is where a lot of people do their stretching. So that's one thing that can contribute to hypermobility is if we're going past a physiological barrier, we're introducing stretch into connective tissues, ligaments, joint capsules, tendons, which can be good, can be bad. Past that, what do we have? Past that, we're at the anatomical barrier. If we go past that, we have injury. So hypermobility can be natural because you could have a horse whose joints, just the way they're designed, they have a lot of movement, right? Like people who are double jointed. Or a foal, you know, a young horse is going to have a lot more movement available because things just aren't totally gelled yet. But as horses get mature, they come into their natural joint range of motion, right? So a lot of the work that we want our horses to do when we're asking for a lateral bend, they're going to go to the physiological barrier, and that's good. But if they go past the physiological barrier into the elastic barrier, they may be starting to introduce strain or stretch into, you know, things like the joint capsule that we don't really want to be stretchy. We want it to be elastic, but we want it to be providing stability. So I don't know. Hopefully that.
Yeah. So basically, I think what you're saying is there's the structure of the bones themselves that determine a certain amount of movement, and then you can go past that, but you're getting into this soft tissue area, which can do some, but if you push that too far, you're going to start to basically interrupt the function of those soft tissues and perhaps damage them in a way that they don't recover.
Correct. Or, you know, they change, they morph into something that's going to be less elastic or less defined, right? So it's not that, like our ligaments, obviously, ligaments connect bone to bone. Maybe that's not so obvious, but that's one of their main roles is connecting bone to bone. So they help to limit the cycle of movement. So when we get to the end feel of the joint, when we get to that physiological barrier, the ligaments are going to be communicating to the brain to say, like, that's probably where we want to stop, because if we keep going, we could be going into dangerous territory, right? So your ligaments are stabilizers in a way. So if I'm forcing things into that elastic barrier all the time, what I'm doing is I'm overriding that ligament's ability to stabilize the joint, and eventually maybe even stretching those ligaments. And then we get that acquired hypermobility, or maybe it's a sudden occurrence. It's a sudden jar that stretches the ligaments. And then if they don't have time to recover and get their elasticity back, we've got this hypermobility, more movement. It's the horse goes into that elastic barrier too easily. And so it's a little sloppy. It's not as stable, right?
So to kind of bring it home to us, like if we twist our ankle and we damage the ligament, then A, it takes a long time, and B, it's weaker and it feels like, oh, I'm going to do it again. I'm going to do it again, because that ligament is now not able to stabilize the joint well enough until it's fully recovered, which obviously, because it has a low blood supply, takes a lot longer time.
Right.
But repeated injuries of that ankle, and pretty soon your ankle's unstable. Like you can't do figure skating without a brace because you need the stability.
Yeah, right. Yeah. You're talking like you know me. This is my story. Right, exactly. Like I have a hypermobile right ankle and I have a hypermobile right SI joint. And so I have to stabilize those all the time. So, I have to stabilize by strengthening the muscles and the tissues that support them, but I also have to support them sometimes externally because they just don't have the inherent stability that they did when I was in my 20s. Right.
Right.
So same for our horses, but and sometimes that's just because of their lifestyle, things that they've done. But a lot of times it's because of the mechanics being used in their training, in their riding, right? Or in the body work that we're providing them, where maybe unintentionally we're introducing hypermobility in the quest for mobility, because and this is where MLT can be really helpful, because if the muscles are stiff or rigid, but we're through force creating movement at the joint before the muscles have had a chance to adapt or have that stiffness addressed, then the ligaments get into this argument. So this is the premise of manual ligament therapy. What we know now, thanks to research that was done throughout the 90s, is that ligaments are not only there to attach bone to bone, they're not just there to help limit movement beyond a certain point. They are also very rich proprioceptive organs, or proprioceptive tissues. Proprioceptive meaning like they are a big part of the communication that's going on between the musculoskeletal system and the central nervous system. They have certain receptors within them that are super sensitive. We call them Ruffini corpuscles. They're one of the most primitive neurological receptors, and they're kind of trigger happy. Like they are the first things to respond. If we look at like in embryology, if we look at a blastocyst, like a new being when it's only like 16 cells old, and you poke it, there's a response. There's already a response, right? There's already the cell membranes are already able to kind of be like, whoa, what's that? So that's, the development of these Ruffini corpuscles. We see it even in like really lower invertebrates. And the ligaments contain these corpuscles as well.
And the horse's hoof does too.
And the horse's hoof. Yes,
yeah.
Absolutely.
So, I forgot my question. Never mind. Keep going. Oh,
yeah.
Well, it's, like some people, like we see like contortionists and they're hypermobile. And that's why they can do things. But for I'll never forget, and I'm just going to tell this very brief story, but one time Arthur Cottas, who was first chief rider of the Spanish riding school, when he was retired, he walked up to me one day and he said, I'm a really stiff rider and I ride well. And there's a guy at the Spanish riding school that can put his feet behind his head and he's a terrible rider. And then he walks off. And exactly. And basically what he's saying is just hypermobility does not make you a better rider because you can't stabilize.
Exactly. And it is different, like I said, there's acquired hypermobility and there's like innate, like some people are more hypermobile, and some horses are, and their bodies grow that way. And so if they learn stability within their own movement pattern, they may be great. They may be top performers, right? Or they may just be, really super functional, happy horses. But if it's acquired because they're structurally designed to be stable and that stability is interrupted or compromised, then that's not something they're going to easily recover from. They're not going to get used to that. Well, they might get used to it, but they're not going to perform better. So yeah, you could have somebody super flexible who's a great rider. You could have somebody who's hypermobile who it really interferes with their riding.
So that I remembered my question. Static stretching, there's a lot of research now that's coming out and saying static stretching isn't good. And I think you kind of touched on that when you said when the muscle is stiff and you're stretching other things because the muscle isn't, did you say warmed up or can't respond? I can't remember.
Yeah, it can't adapt. It can't adapt because it's contracted. Yeah, so at the Northwest School of Animal Massage, we teach a form of stretching called passive repetitive stretching. It's based on the work of a man named Aaron Mattis, who developed active isolated stretching. And active isolated stretching is like what most of the professional athletic teams now are adopting, because in certain instances or at certain times, static stretching can actually be harmful. There's a place and a purpose for static stretching. Static stretching, a classic example would be like yoga is a type of static stretching because you are going into that elastic barrier and then you're hanging out there for a period of time. The biggest mistake I see when people are doing stretching with their horses is they position the horse in the elastic barrier, but they don't stay there long enough to allow for the adaptation of tissues. So when you're doing a static stretch, you really should be there for up to a minute or more. If you do a static stretch where you go, past the elastic into the elastic barrier, and then you just come right out of it, you've actually probably just taken a step backwards because the body's going to reflexively splint. The ligaments are going to say, no, we're not going there. And you haven't given them the time to say like, oh, okay, we can actually be here and be safe. Now let's let the tissues expand and stretch and soft tissues adapt.
So these feeding receptors that are in our ligaments then are kind of like we either freak them out by doing something that doesn't give them a chance to kind of figure out what's going on, and then they react badly. Or if we do it in a different way, they can...
Yeah, they act reflexively. So they act either to protect or to allow or assist that adaptation. So for the ligaments, for example, if I'm continually taking a joint into a dangerous position, the ligaments are going to start to communicate. This is what's fascinating about manual ligament therapy. The ligaments can communicate to the brain and say, hey, here's what's going on. Do we want to change something? Do we want to not do that or do something different? So they can talk directly to the brain and to the spinal cord, or they can go directly to the muscle outside of the central nervous system, and they can recruit and de-recruit muscles, meaning they can cause the muscle to either contract or relax without talking to the brain first. This is a feedback loop that was discovered by Dr. Solander. He did his research on ligament afferents, meaning how do ligaments send signals out? And he discovered this feedback loop, which that was what our goal built the manual ligament therapy on, is this idea that ligaments can also cause muscles to be stiff because the ligament thinks this joint is in a precarious position. add to that the fact that if this joint has been being put into a precarious situation over time, that ligament has developed a bit of an adhesion because it's constantly being like put past its limit and then slack, and then put past its limit and then slack. And we get what's called a trigger point, but it's forming in the ligament instead of the muscle. Right? So just to kind of go backwards. So we have this hypermobility, or this position of instability. It's creating strain on the ligaments, and the ligaments, the Ruffini corpuscles, can signal to the muscle, hey, shorten up, or let's help stabilize this joint. The joint can't stabilize itself. Let's create stability through muscle tension. So we get hypertonicity, or tension in the muscle, caused by the ligament recruiting the muscle because the ligament feels damaged, right? So we get these trigger points forming in the ligament, and now the ligament is going to have this conversation with the muscles independent of the central nervous system. So you can have your central nervous system telling the muscle to relax, and the ligament saying, no, don't. And so we get this tug of war going on.
Wow. This is fast. My brain is going off in a million directions, but okay, I'll try to stay on track here. So, okay, this is super cool. And it's so interesting that the more we learn about some of these systems, like, I'm sure it's tied into the fascial system too, because aren't they all like good friends?
Absolutely. Well, I mean, the ligaments have fascia invested in them. Where the ligaments attach onto the bone is a fascial attachment, because the ligament is surrounded by a fascial membrane, and that fascial membrane attaches into the periosteum, the fascia around the bone. So, it's all fascia. At the end of the day, there's no separation there. But because the ligament tissue is a unique tissue within that fascia, it has capabilities and responses different than the muscle that might share that same fascia, right? So certainly there's an implication that there's a fascial element to this. Yeah. But what's fascinating is, so manual ligament therapy is most useful in chronic repetitive injury situations, or just like when we have a chronic or chronic static posture, right? So that maybe there isn't even an injury yet, but we're certainly setting the stage for that, or we've had a repetitive injury. Your example is a classic one. Rolling your ankle, maybe there's some ligaments get stretched, or even some lesions, and they start building up adhesion. Once you have that trigger point forming in the ligament, now, like, you could have your ankle recovers, you do your PT, you get back to doing all your normal activities, and everything feels good. But every once in a while, you still feel like, oh man, my ankle's really stiff this morning, or a certain thing is hard, or if I, too long of a gallop and my ankle starts to bother me a little bit. And you're like, but why? It's not injured anymore. But if that ligament still has a trigger point in it, when it's stressed, it's going to recruit the muscles as if there was a joint injury. The ligament thinks you're still injured. And so it keeps recruiting the muscles, even though the joint says, no, I'm fine. And the brain says, you're fine. The ligament says, I don't think so. So,
and so by recruiting the muscles, it's trying to stabilize that joint beyond what it feels like it can do, for lack of a better way to say it.
Exactly. So going back to what I said at the beginning, I was seeing these horses who were like hypermobile one day and rigid the next day. And I was like, what is going on? Is this just a buildup of waste products that's causing stiffness? Is it a pain response? But once I had the manual ligament therapy piece, I was like, aha, they're responding to that hypermobility by splinting around the joint. But the typical approaches that I was taking were short-lived because the central nervous system and the ligament were at odds. But once I learned that I could go in and release the ligament trigger point, you get two things. You get almost a 80% reduction, usually, of the hypertonicity in the muscle, and an increase in range of motion at the joint, but an increase because of stability. So I kind of
talk about that a little bit, about how can you have an increase of range of motion from stability?
Because remember, mobility occurs best around a stable platform. An example would be like, a tether ball. I don't know, that might be an outdated example, but
it came up in my connections word list the other day. So on New York Times, it's fine.
Well, 2 days ago was the 20th anniversary of Napoleon Dynamite. So maybe,
my God,
maybe there's a tetherball analogy there too. Anyway, I mean, tetherball's super mobile, right? It's at the end of a long rope, which would be your muscle, and whatever you want to think of the ball as your wrist or something. There's a tremendous amount of mobility because there's a pole in the middle that's very stable. So like you need that central stability to get effective movement that isn't dependent on the joint going to an abnormal position. So like the stability is the underlying principle behind mobility.
Well, and aren't certain joints more designed for mobility than others? So when you create the stability in one place, it allows the joint that's supposed to be more mobile to do its job.
Correct. Yeah. Absolutely. Yeah. So that was just revolutionary for me, for my practice, to be able to introduce the manual ligament therapy for those horses. Now, it's not going to solve every problem. Like I said, it's primarily when you have those chronic repetitive scenarios. And it doesn't have to necessarily be a chronic repetitive injury. It could be a chronic repetitive posture. But the horse is like chronically doing something. After a certain fatigue point, they no longer get a certain lead change. Or, the third day of the week at the jumper show, they're starting to take rails in front because they're not picking up the right front leg the way they were on day one. So, we might just associate it with fatigue, but sometimes it's this hidden ligament stress. So yeah, that's kind of in a nutshell. Wow. And I do have some slides that we can use to kind of illustrate this if you want. And I also have like one kind of classic example where introducing the Surefoot pads gave me a whole new level of just feeling like the horse, not only did I help to reintroduce that stability, but then the horse's awareness of it completely changed their movement. And I wish I had done videos of some of these things. I will probably in the future, but I can walk you through a really common scenario.
Yeah, no, that'd be awesome, because now I'm wondering if the pads don't provide the ligaments with the opportunity to feel okay to allow other things to happen. I mean, my brain's going crazy. Okay.
Mm-hmm.
All right.
Yeah.
So to share, just go up to that top little menu and it says turn screen share on, and you can share your screen.
Just trying to find my desktop.
Yeah, that's always fun.
Yeah.
So it's really interesting. Because I know that the hoof is rich in Ruffini receptors in the sole, and I've always figured there's some sort of connection there.
Yeah. But so are you seeing slides or no?
No. So you go to turn screen share on. Let's see if I do it. And then you've got to pick the screen you want to share.
So if I put an entire screen, can I pull up from my menu? Chrome tab. It's using Chrome tab. I don't use window.
Probably the best thing is to have the thing open that you want to share so it shows up on that.
Okay. Yeah. Let me try that.
Yeah. Then it'll go, oh, there you are. That's what you want to look at.
Sorry.
No problem.
Technical thing is not.
We got busy chatting about other things instead of just doing the drill of testing this out. So.
Yeah. Well, and I can also do it without if I need to. Because for some reason I'm not seeing.
So when you go to turn screen share on, you're not seeing the window that you want to share?
No.
But it is open.
Yeah.
You could try your whole desktop. Let's see. Up there you have window. Oh, on your choices, you have Chrome tab, window, and entire screen.
Yep.
Go to window and see if that doesn't give you the option.
Oh, yeah. Ta-da. There you go. Genius.
Well, I'm not usually the one screen sharing, so I'm... Okay.
There?
Yeah, we got it.
We got slides. Okay. Well, you're probably very familiar with this saying. It's one of my favorite. There is no limit to the improvement of movement, right? But I think we, like we've said, we kind of got into this idea that the only improvement to movement was more movement instead of being able to improve movement through stability. So that's what I think MLT kind of helps us do. And some of this is repetitive. We've talked about this, that the ligaments, now we know that they have a lot of proprioceptive value, that they provide us with knowledge about the position of the joint, but also that they have these reflex arcs where they can talk directly to the muscles and they can create gain or, contraction in the muscle, or they can de-recruit the muscles. And each ligament, I'll just mention this, each ligament has like a specific set of muscles that they most communicate with. And it's not always the ligament. It's not always the muscle you would associate it with. For instance, the supraspinous ligament spans the entire spinal cord, but it also communicates with muscles that have no attachment at the spinal cord. So sometimes the ligament that is turning a muscle on and off may be kind of at a distance from that muscle. So that was the 5 years of trying to figure out
that's
which
kind of
ligament.
mind-blowing.
Yeah. Sometimes it is the ligament associated with that joint, but it isn't always the case. So this is just kind of the history of manual ligament therapy.
I don't think we're seeing the slides change. Are you on? Have you? Right now we're seeing like editor version. So maybe just turn your slideshow on.
Okay.
Because we've got the dog with the Feldenkrais quote, but that's the only slide we're seeing.
That's the only slide you're seeing. So when I advance, it doesn't advance.
Yeah, because I would tell you go back up to your window and choose the window that's the actual slideshow playing. Oh, there we go. Better.
That better?
Yeah.
Okay. So, so now you kind of see like the characters involved.
Yeah.
So many horse people are familiar with Dr. Logan. He was a human chiropractor, and he worked primarily with people with scoliosis, women primarily. And he was the one that discovered that if he put pressure on the sacrotuberous ligament, it would create dramatic decreases in the tension of the epaxial muscles, or the muscles on either side of the spine. And we call this the Logan Basic. It's like the first move that equine chiropractors learn to just release tension in the back muscles. But he just kind of happened upon it, and he knew it worked, but he didn't know why, right? So years later, thanks to the work of Dr. Solomonov and Dr. Solander, they kind of were doing similar research at roughly the same times. They discovered this role that the ligaments have in proprioception, and that helped to explain why, if we put pressure on this ligament in the pelvis, why are we getting changes in the muscle tone of the spine? So then, as I've mentioned, Arik Gold took that information. He was a human massage therapist and a chiropractic assistant, physical therapy assistant, who was frustrated by the fact that he was working with a lot of athletes and they were coming in with these chronic problems that he could resolve short term, but he couldn't resolve long term. And it was really hard on his body because he was having to do a lot of very deep tissue work. So he was looking for a solution. And so he went to, studying the ligaments in depth. There's also a gentleman up in Canada that's doing some similar work who I'm really interested in pursuing his work as well. And then I, of course, came to know Arik through the classes that I did. So this is just kind of, the evolution of MLT. And as you can see over time, the technique just got more defined, more directed, and the characters got better looking.
Yep. Is there any chance that you can, right now we're still seeing your screen that is editor version. I don't know if you can, because it says like play from beginning and that sort of thing. And it's
yeah.
If you can make it full screen, that would be awesome. Or choose the window that is the actual playing.
Yeah.
No problem. Oh, there. Let's see what happens there.
Yeah.
No, we saw you click on that, but it didn't change what we see. That's weird.
It is weird.
Just go back up to your screen share and just check it again. Yeah. Somebody's saying they can't see it very well.
So it seems like it should be that one.
Yeah, but we've got the whole menu on top, beginning, current slide.
Yeah, I see that. But I'm not getting any response.
Somebody's saying hit present.
Well, none of this is live. So like if I click on this, it's not live.
Okay.
And if I click on mine, you don't seem to see it. So
okay. No worries.
Well, if the slides aren't helpful, I can just talk through them because
oh, we like the pretty picture though.
I know. I think this is just it's just an image of it. It's not the real, but it's only giving me that option.
If you start your slideshow and then go and choose it, does that work?
Well, that's what I did the first time. Let's see. No?
Yeah, no, it's the same thing. Oh, well,
yeah.
No worries.
Yeah. The joys of PowerPoint. So which do you prefer, the slides with the menu or no slides?
Anybody out there have a preference? Just type it in the chat. Let us know.
Because I can easily just talk us through what the slides say.
They're not telling me. So just go ahead and talk us through.
Okay. So as we've said, the ligaments are going to recruit the muscles. And so when we see those patterns of like hypertonicity in the muscle or tense muscles that just keep coming back, we work on them, they soften, they're good for a while, but they come back and the horse continues to exhibit instability. Then that's when I go looking for these ligament trigger points. The beauty of the manual ligament therapy is it combines movement with the body work. So, which a lot of techniques do. So once we kind of suspect that we have a ligament trigger point involved, then what I do is I have to position the joint in its shortened position. So let's say I palpate, and I'll give you the classic example, the one that I mentioned that I use the Surefoot pads with a lot. This would be horses where I'm seeing like any horse that's had laminitic episodes, or horses with saddle fitting issues that have soreness in the withers. So when I palpate and there's soreness or some response and there's hypertonicity in the rhomboid muscle, then it's often accompanied by a shortened stride. Right? So that's kind of classic. We've seen that for years, and everybody has an approach for it that gets some resolution. The horse feels better, the muscle feels softer. There's not as much of a pain response, and maybe we see some increased stride length, but then, a few days later, we're back to square one. So what I found is that those horses often had ligament trigger points in the check ligaments. And what was really interesting was I started to see a correlation between if it was the superior check ligament above the carpus, they also had asymmetry in the multifidi muscle or the rotator, muscles of the neck. So those horses often had like a lateral bend in one direction or the other. And on one side of the neck, right through the bony column, there'd be kind of that lack of development in the muscle. And on the other side, there'd be either hypertonicity in that area or hypertrophy, like overgrowth of that muscle. So asymmetry in the multifidi often accompanied those horses that had pain or tension in the rhomboid and had adhesion in the check ligament, the superior check ligament. And then what was equally interesting was that horses that I worked with who are more in speed disciplines, so my event horses, race horses, some of the jumpers, they would also sometimes have adhesion in inferior check ligament, and they would have had a history of deep digital flexor tendon issues. So if I did the release, the manual ligament therapy release for the check ligament, we would see increased range of motion at both the pastern and the neck in the direction where the multifidi were weaker. So I know that's a lot.
Wow, but it's just like, wow, who would have, we don't really think about the check ligaments, right? We kind of think, oh, they're that thing there that nobody talks about.
Mm-hmm, mm-hmm, right. Such a fascinating ligament. I mean, horses are just mind-blowing in their adaptation because I don't know very many other species. I'm sure there's probably some where, the check ligament is an anomaly because it connects bone to soft tissue. It doesn't connect bone to bone. It connects bone to tendon. And the suspensory ligament is kind of an anomaly because it used to be a muscle and it still has muscle fibers in it. So horses, from a ligament standpoint, have some pretty fascinating physiology anyway. But yeah, I think you're right. We underestimate the check ligament until it's injured, right? But obviously it's there and it's proprioceptive. So it's communicating a lot about the position of the carpal joint. But what was interesting to me, and I've just been able to kind of play this out because of running a retirement facility and a rehab facility. I've had a number of older horses that came here because they had laminitis, repeated incidences, and were no longer rideable. And I've also had, horses that come here with sleep deprivation or were diagnosed with narcolepsy, but ended up just having sleep deprivation. And they had that very, very similar, whether it was the laminitis or the sleep deprivation, they had that same kind of instability, deep digital flexor irritation, and check ligament adhesion. So I got to kind of have a good, nice sample group to try this out on. So then when you came out and you did the Surefoot pads, I was like, oh, well, one of those horses was no longer with us. Unfortunately, I would have been amazing to see what she did with the Surefoot pads. But my own horse, PSSM horse, prone to laminitis, had such an improvement with the Surefoot pads during the class that then I went back and said, like, okay, but now what am I going to do with him in terms of multifidi, right? So in that's one example, but in several cases when I've been doing manual ligament therapy on the horses, I'll use the Surefoot pads for 3 reasons. Initial assessment. So if they have ligament trigger points that are recruiting the muscles, I can kind of trick the central nervous system because I can put the horse in, I can let them choose a position of comfort, right? So I'll just put the pads out and let them choose, like, what pad do you want in the front end, and get them comfortable. So now the brain is going to be like, okay, awesome, we can all relax, like, life is good. But the ligament will be like, no, it's not. We're still injured, and it will splint the multifidi. So then the horse will have that stiffening and lateral flexion to one side, unilateral lateral flexion. So I can use it as an assessment tool, and it kind of helps me to separate out, is this just environmental? Is this, a training issue? Is this just that horse's pattern? Or do we have a ligament trigger point involved that's recruiting these muscles, even though they don't need to be? I also use it as, a follow-up. So once I've done the manual ligament therapy release, I can see that there's increased range of motion because I can do my range of motion tests, but I need the horse to be aware of it in a new way too. So then I put the pads out again and I give them options, and almost always they go to the wedge after the check ligament is released.
Heel high or heel low?
Heel high.
That's what I figured.
Yeah. So that's really interesting to me because sometimes they choose the wedge in the beginning, sometimes they don't, but they often, almost always do afterwards. And then they, spend some time on it and kind of find themselves. and then I can repalpate, and rhomboid is comfortable. Multifidi are comfortable. Now they're still asymmetrical, right? So now we just have to add that into our training to get them to start using their neck differently. But, how many times do we have a horse where they're in that chronic posture and they end up with a deep digital flexor tendon injury, or they end up with rotation that may have been preventable because the ligament is causing, the pull on the joint and the pull on the muscle, in addition to whatever the symptom, the original symptom is. So again, not like a fix, but definitely a piece of the puzzle that maybe we didn't have before. So then, I take the horse out and move him around, and invariably the stride in front is longer, and they're more stable on the offending leg. So that's kind of the magic of combining the Surefoot pads with the manual ligament therapy.
And how many people know how to do manual ligament therapy in the horse world?
Well, we're the exclusive providers of the training. So we've got a couple people in the chat room who do MLT. I see Olga's there. So people that have taken the MLT training, I have a number of vets, because I taught the manual ligament therapy for 3 years at the American Veterinarian Chiropractic Association conference. And the feedback there was tremendous. A lot of small animal vets, and it's a really helpful technique in dogs with IVDD, intervertebral disc disease. Again, is not going to solve the problem, but it removes a lot of the aggravation, because they're getting, muscle tension on those joints that isn't necessary, especially as if they're getting more stable over time. Like any arthritic condition over time is going to get more stable through fusion, right? But the horse might still exhibit, pain or discomfort, or the dog might still exhibit pain or discomfort because the ligaments are still recruiting the muscles unnecessarily. So sometimes from a pain management standpoint, it can be a really effective tool. So I would say numbers wise, I've probably trained several hundred. How many and I do have a number of people who tell me, like, once they learn this technique, they use it in almost every session. Now, granted, if you don't have chronic repetitive stress scenarios, this is not going to be the tool. But very often we are facing those.
I'm just, like chronic repetitive stress scenarios in humans and horses is like all the time. Like,
yeah, I mean, probably once a horse is past the age of 8, there's some chronic posture to be dealt with for humans.
Well, and I'm just thinking about riders who have forced themselves into positions that are not advantageous to overall health and good function, right? Because they're trying to achieve a look that the instructor said they're supposed to be, and then what kind of problems that sets up in the students. Anyway, my brain is, like I said, it's running away.
Yeah, that was how I felt for the first, well, still, because the interesting thing is we started by just trying to transfer what we knew from the human MLT. Like I know that if I have rotator cuff issues, I know which ligament in the human I'm going to use to do an MLT release for the bicep. But it's not the same for the horse necessarily. Especially bicep's a great example, because bicep and tricep in the horse are very different than bicep, tricep in the human.
Right.
So we had to just go and test it out. And there's no manual. I mean, there is my manual, but
I was going to say I hope there's one now.
There's nowhere for me to go to say, like, well, what ligament turns on the multifidi? What muscle turns on the deep cranial pectoral? I didn't know. So we had to just trial and error.
How well mapped out is that now?
So we have probably about 45 of the muscles that we have a clear pathway for. But I just went to like the major muscles, primarily the synovial joints. We haven't gone down to the level of, I'm sure there's a visceral component. And that's what fascinates me kind of now is as doing visceral therapy, I want to kind of figure out, like, how do I release a trigger point that's influencing the diaphragm or the, the pyloric valve or something.
Right.
So I would say we've got, a good 45 to 50 muscles, which is what the what the classes cover is, the first class covers the theory of MLT, some of the stuff we've talked about here, and the protocol, like how do you do an MLT release? There's basically 6 steps. But then you have to learn each muscle independently because each muscle might have a different ligament. So you have to learn the ligament location. You have to know the kinesiology of the muscle because the protocol involves something we call reciprocal inhibition. We right. position the body, and then we have to get an antagonist to fire. And that was something we had to figure out in the horses as well, because in humans it's easy. If I want to release somebody's if they have a trigger point in one of the ulnar ligaments, I can position their arm, I can anchor the ligament, and then I can just ask them to resist me and do the movement. But you can't ask the horse to do that. So you have to have a mechanism. So, we've developed that as well. And it's very, very effective.
Can you define trigger point just to be really clear?
Yeah, because a trigger point is going to be different if we're talking about muscle than if we're talking about ligament. So in a muscle, a trigger point forms when the functional segment of the muscle fiber, what we call the sarcomeres, they get contracted, and then it forms an adhesion. So you have, a muscle fiber that should be this length, but its segments have become contracted, and then they've become glued together. In the area of a muscle spindle fiber. So the muscle spindle fiber is a proprioceptive nerve. It delivers the message from the brain to the muscle to turn the muscle on. So this is kind of simplifying things quite a bit, but the muscle spindle fiber is the on switch for the muscle. So when a trigger point forms in the muscle, in the area of a muscle spindle fiber, it causes that pain on pressure, because when you press on a trigger point and press on that adhesion, it fires the muscle spindle fiber. So you get spasm, right? The muscle tries to turn on. So that's different than a ligament trigger point because the ligament doesn't have sarcomeres. So we're not getting that like folding of the ligament. What we get is something called hysteresis, or basically it's just shearing or tearing in the ligament. So if you have the ligament and you're constantly putting some kind of force on it, it's going to start to shear at the point of force. And now you have damage. That damage, because the ligaments don't have the vascularity of the muscle, you get adhesion where there was the damage. So, a muscle can have a trigger point and the fiber isn't damaged. It's just tangled up. But a ligament, a trigger point in a ligament always involves some shearing or damage to the ligament. And now that ligament, it isn't as elastic. It can't move as much anymore on either side of that adhesion. And that adhesion is stimulating the Ruffini corpuscle. So a muscle trigger point is acting on a proprioceptive nerve, the muscle spindle fiber. A ligament trigger point is acting on a proprioceptive organ, the Ruffini corpuscle. So both cause pain and both kind of create this sense of that tissue being in jeopardy. So when the ligament thinks it's in jeopardy, it's also going to always think the joint is in jeopardy because that's its job.
Right, protect the joints. Somebody's asking, can this be helpful for a horse who is over at the knee? One of my horses cannot fully straighten his knees. His carpi are always slightly bent when he's standing. This causes stability issues when he's sleeping, standing up, or under sedation, as his front leg stay apparatus doesn't work fully.
Yeah. So this is, it's a chronic situation for them. There is going to be a difference between a horse who is, over at the knees conformationally. They've always been over at the knees. But in my experience, horses that are over at the knees their whole life, they grow with that, and they tend to be more stable than a horse that becomes over at the knees because it becomes acquired. Right. So that's kind of the first thing we have to untangle is like, is this horse's structure, or was this acquired because of, injury or posture? And so it's often the fact, like certain breeds, they're more of them are over at the knees. A lot of thoroughbreds can be over at the knees a little bit, and some of them function perfectly fine that way, and it's not a problem until maybe they do get older and the other things are becoming unstable, then the stay apparatus is going to be compromised. But a horse that maybe appears over at the knees because they've had injuries higher up in the leg, or because they have excessive tension in the flexor muscles in the forearm, that this could be very helpful for that. So what I'll often see is, like, it may not change visibly, like they may still look over at the knee, but we see a visible change in their stability, in their comfort level, and in their stride length.
So, we're finally realizing that DDFT injuries are over time, repetitive use, chronic, and then finally it blows, right? Unless it's a traumatic acute situation, injury in the trailer or something like that. Apparently, more and more now, the thought is that this is something that's happening a lot over time. How do tendons do tendons have a similar trigger point issue that's going on like a ligament? Could we be looking at manual tendon therapy?
Not to my knowledge, but it's possible. I'm not going to say it's not possible, but not to my knowledge. They don't have the same proprioceptive language, but we used to say that about ligaments. Right. So, for many people, when I say this, ligaments also have the ability to turn on muscles, they're like, no, they don't. It's like, well, yeah, I mean, the research is there. So, and I see it on a daily basis. So yeah, is there a possibility that there's a tendon element as well? I'm sure, like, obviously there's fascial element to it. But I think the trigger points.
Ligaments, we're talking to the muscles. That could also be what's causing the problem with the tendon.
Yeah, and I don't know that the tendon would then recruit the muscle. So I think that's kind of the big key here, is that the ligaments are able to create hypertonicity in the muscle. So we can address hypertonicity at the muscle level, but if it keeps coming back, then obviously just addressing it at the muscle level is not solving the issue. So then you have to say, well, is it a nerve entrapment? Then you address it that way. Is it a ligament issue? Is it a ligament trigger point? Then we have to address it that way. But I will say this, as long as that ligament trigger point exists, you will never get full resolution. And so it will continue to be chronic. Maybe it gets better to a degree because of the attention you're giving it. But as long as that ligament trigger point exists, that ligament is going to keep thinking that joint is in jeopardy. Right. So it's just going to keep recruiting the muscles. So when we do address that trigger point, that's why we see this like rapid decrease in the hypertonicity, but also it sticks. Right? I mean,
yeah. So I mean, but that's a huge point that, I'm always looking to see when I do Surefoot pads, how much sticks, right? And if it doesn't stick, right, it's like you need to start digging deeper because something else is going on. Right. And I'm sure that's the same with this, is that you're, how do I put this? So many times I've seen people have a massage therapist and they're constantly coming out and addressing the same thing over and over and over. It's just palliative. You're not actually solving whatever the underlying problem is. And until you get down to the root, you're just kind of, putting another coat of paint on whatever. Yeah.
And palliative is great, right? I mean, that's great because you're going to have horses who, because of their history, their injuries, or their lifestyle, they're going to be things that they deal with their whole life. But if I can take back a couple layers of the onion and make them more functional and they can do their job happily, even if that's all I can do, there's still a merit to that. But you're right. If we're not getting to the underlying problem, another good example of that would be, I have used manual ligament therapy a lot for the DSLD horses, and seen some really nice benefit for that. But you have a degenerative condition. It's metabolic. MLT is not going to solve that, but it is going to take some pressure off, and it may be because the muscle being recruited potentially isn't at that joint. you're not taking away stability. You're not taking away, or you're not adding to the pressure on those joints. So I have seen some really nice effects with the DSLD, but to your point, I had a mare here for a number of years, and she had fractured her fetlock pretty badly at a young age. And so she'd been in the pasture her whole life, and she developed this huge hygroma over that area. She was never rideable, but she was a lovely, lovely animal. And surprisingly sound, as she lived to be 34 with horrific DSLD, the worst sinking I'd seen. But that foot, when we did finally have to euthanize her, we did a necropsy on that leg. And I was like, the MLT never really seemed to help her with that, but with the other legs it did. That bone was still broken. It had never healed. So it was like, yeah, sometimes there's that underlying thing that you can't address.
Right.
Where, keeping her comfortable was really important, but we couldn't solve the problem. So that, that horse shouldn't be out there jumping, but if we can't solve that problem, but we can maybe at least keep them comfortable.
Wow. Well, Lola, this has been really, really fascinating. And I'm how can people learn more about MLT for people?
Oh, yeah. Well,
I'm thinking about, I have a lot of people I haven't.
One thing that's interesting is, so Oracle relocated. He's in Mexico now. He's in Guadalajara, and I do go down and teach with him. And he still is teaching. Mostly, he has a very, very busy practice there. But he still goes around and does some teaching. So the manual ligament therapy classes that he taught are not available anymore in the U.S. There are, still a handful of practitioners up and down the West Coast that he had trained. However, one of his proteges developed the MELT method, which is very popular in humans, and it's based on MLT. It's a little bit different because she comes more from a yoga background, so she's more into the movement side of it. So you could, if you're interested in the human aspect, you could look up MELT method, and I forget what the E stands for, but it's manual something ligament therapy. And then for the horses and dogs, we teach the courses, and we have an online course that's just kind of a primer. So people can take that in advance of doing the hands-on training. And right now we have a certification course that's 3 days long, and then there's an advanced course. However, next year, we're going to be launching an online version of the manual ligament therapy. So once you've learned the protocol, you can just get an installment of a muscle each month, and then you'll have the collection of muscles, or you'll be able to just go and target, this horse has this issue, which muscles do I need to release? Because really, we're treating the ligament trigger point, but what we're doing is we're releasing the hypertonicity and stabilizing the joint. So
now, is that something a lay person can take, or do they have to be?
Well, you have to have a good understanding of the biomechanics because of the reciprocal inhibition. You have to know which muscle is it that I'm targeting, what is its action, and who is its antagonist to be able to set up the reciprocal inhibition. So it's really more of an advanced technique for people who already have a working knowledge of the anatomy and physiology, and also, have pretty good palpation skills, because not all of these ligaments are just easy to find.
Right.
So primarily the people that take our courses are either already massage therapists or body workers, or, like I said, a number of veterinarians have taken the course, chiropractors. So definitely
I know that you have a hoof there, okay, because you showed it to me earlier. And we know that there's a lot of ligaments in there, right?
Yeah.
Okay. So now I'm wondering, from a farrier barefoot trimmer perspective, do you have, is this something that barefoot trimmers and farriers are interested in or learning about, or?
Absolutely. Because, the hypertonicity is going to be in the forearm or in the upper, in the gaskin. So, if I'm looking for something that's influencing the hoof, it's higher up.
Right.
But like I said, this deep digital flexor tendon, if I've got a ligament trigger point in the inferior check ligament, it's putting stress on that system. So if you're, trimming horses that have a history of laminitis, or they have a history of suspensory issues, it's going to be a different ligament. But then definitely you need to relieve the splinting that's going on up higher if you have chronic foot issues. So I think that's not my area of expertise. I mean, that's something that's on my bucket list, is to take a farrier course, but I would say that's probably like my weak point in anatomy would be hoof anatomy. So I think that's something that somebody could explore and probably find really good application for.
Well, because I'm just, you've got your farriers who are working on those feet and seeing and feeling all this stuff. And wouldn't it be great if they actually knew how to do some of this to alleviate things that would then benefit?
Absolutely. Even if it's just because, my farrier is wonderful because I have an older population and a lot of them cannot really stand on 3 legs for very long. So he has to be pretty creative. But the fact that even if it's a horse who's a little bit difficult, or they're having difficulty on 3 legs, I mean, it's not the horse that's difficult, right? It's the situation that's difficult. Right. Being able to release their tension just going to make their job easier, exactly. Even if it isn't necessarily contributing to the biomechanics of the foot, which probably true as well. But even if it's just that, if I can do this release, the horse is more stable, feels more stable on that leg, then I might have an easier time getting the other leg off the ground. Yeah.
Well, I don't know if you're going to the PHCP in Illinois in October.
I'm not.
Oh, I'll be there.
Oh, we just need to get you trained in the manual.
I was going to say,
but I'm really excited that we'll be launching that program next year. So then it can reach a much broader audience.
Right. Because I can see how this could fit in so nicely there with, the barefoot trimmers are really thinking hard and looking at different things. And not that the regular farriers aren't, but that.
Mm-hmm. Oh, you froze up on me. So I lost Wendy's feed, but I do see that there is a question in the chat. Would this be helpful for a horse whose lower hock joints are fusing or have fused? So again, yes, because it's going to take a layer off if there's splinting going on in the plates, in the muscles above the joint, to help reduce the wear and tear on the plates, or to help reduce the movement on the plates. So in that case, for horses that have hock issues, I always target the semitendinosus muscle, the large hamstring muscle, sometimes also the bicep femoris, and the gastrocnemius, because if those are hypertonic or they're being recruited by the ligament, then they're going to be pulling up on the calcaneal bone, or they're going to be pulling the hock into kind of a extended position. And that means that then the force, instead of coming into the hock at an angle that agrees with the talocrural joint, it's going to be coming down more extreme. So it's going to be coming into the plates and causing movement at the plates. And that's where sometimes then we see a buildup of arthritic changes there as well. So if we can relieve tension in those areas and take pressure off the hock, that's certainly going to help, even if it's not going to change a degenerative condition in terms of its progression, but it may slow it down, and it certainly may make the horse more comfortable for longer. So that would be my comment there. I think we've lost Wendy, and I think that we are still rolling. So maybe somebody in the chat room can let me know if we're still in the conversation, but I think I'll probably wrap the conversation up. I know we went over time, and I appreciate everybody that came on the call today. And I hope you enjoyed the conversation. And if you have questions about manual ligament therapy, please, you can visit our website at nwsam.com, or you can reach out to me directly at lola@nwsam.com, and just keep helping those horses. Thanks so much for your contribution.